difference between this transplant and a normal transplant is, normally we do transplants, we do about 2 transplants a week. And normally when we do a transplant, we always take a kidney from a living donor, a person who is alive, who has got 2 kidneys and who is willing to donate. And according to the legal framework we have, we require a related donor. Related donor would be a brother, a sister, mother, father, or somebody who is in the family according to the legal definition, who is related, who will donate one of their kidneys. We do a lot of tests on these patients to find out that both kidneys are working. One of the kidney, when we take it out, he can live with the other kidney for life, for the rest of his life, and this kidney matches the patient. So normally majority of the transplant which are done in India, which we also do about 7, 8 a month, are always from a living related donor. The uniqueness of this transplant is that these kidneys have come from a patient who is brain dead. Brain dead means dead, brain is permanently dead, so the patient will not recover. Patient had an accident, head injury, brain is permanently damaged, but heart is beating because the patient is artificially supported by a ventilator. We also know that these sort of patients would eventually in the next 2-3 days will develop a cardiac arrest and the heart also will stop, because this is been studied, and we also know that once the brain is dead, heart can survive for 1 or 2 days and then automatically it will stop. While the heart is beating, if you can take the organs, then you can use these organs to give life to some other patients. Organs include both kidneys, liver, heart, they can take joints, heart valves, a lot of organs which can be taken from patients like this who are actually called diseased donors, diseased or dead donors or cadaver donors in the older term. These cadaver donors, once we decide that there is a potential diseased donor, potential cadaver, that is somebody had a head injury and suspected to have brain death, then nobody can kill a patient. So we will have a lot of tests according to legal regulations. We have an Organ Transplant Act passed by Parliament. According to that act, we have a set of tests which have to be done to find out brain death. We also, the act also specifies who is authorized to do these tests. It cannot be done by a transplant surgeon like me, it cannot be done by a nephrologist, or it cannot be done by a liver transplant surgeon. It has to be done by an intensivist, a neurophysician, and a lot of other group of people who are authorized to do these tests, and these tests have to be repeated after 6 hours. So once we do these tests, we come to know that this patient is brain dead, that is, brain is permanently damaged and this patient will not recover, because the definition of death is brain death, it's not heart stopping. So this patient would be still breathing because of ventilator, pulse would be there because the heart is beating for the next 2-3 days, maybe the heart will beat, after 2-3 days the heart will stop. So before the heart stops, before the circulation of the blood stops, before the organs die, if you can take these organs and give it to somebody, you can give a fresh lease of life. So the main uniqueness of this transplant is that these kidneys have come from a diseased donor. Now, majority of the brain dead patients which we take out kidneys from or liver from are usually young patients, because most people who are involved in road traffic accidents or a bike accident are all young people, but this patient is 67. Now once we get older, we also know that the kidney function would slowly go down, and once beyond 65, majority of the people would not be willing to take kidneys out and use them for transplant, because we do not know how these kidneys are, whether once we put them in the patient, whether these would work normally or not. But we know that this patient who is 67, who died at CMC Vellore, has got a normal kidney function. That is normal kidney function by way of blood test, because both the kidneys are working at the same time. Normally when we transplant, we put only one kidney, thinking that this kidney is enough to take care of this patient's life, and when 2 kidneys come out from a cadaver or a diseased patient, we will put 2 kidneys in 2 different patients. But because of the marginal nature of the donor, that is this, we don't know whether these kidneys individually would be enough to survive, to make a patient, one patient survive. We thought we will put both the kidneys in one patient. So that is another something different which we have done in this patient. We put both kidneys in one patient. Both the kidneys have gone into Mr. Janakramaya, one patient, and now his kidney function is normal. The third important thing about this case is that these kidneys have come from Tamil Nadu. Tamil Nadu is so far away, and given our transportation network, to transport organs from there to here within a specified limit of time is a very difficult thing to happen. And the transportation was to some extent possible because we have Apollo hospitals at Chennai, so that one person can go from Apollo Hospital Chennai to CMC Vellore, collect this ice box containing both the kidneys, and come to Chennai airport, come to Hyderabad airport, come directly to Apollo Jubilee Hills where the transplant was done. This Mr. Janakramaya is a patient from Apollo Secunderabad. The patient was getting dialysis here, but we had to get this patient from Secunderabad to Jubilee Hills Apollo, where the operation could be done safely and very effectively, because transplants are routinely done at Jubilee Hills Apollo. So we have so much expertise in transplantation that this patient from Secunderabad Apollo has come to Jubilee Hills Apollo. Kidneys from CMC Vellore have come to Jubilee Hills Apollo, and this transplant was done within 24 hours. Around 24 hours was the time before taking the kidneys out to the time for the kidneys to be put back into Mr. Janaki. Now, once there is a large gap of time or large amount of time which has elapsed before the kidney has been transplanted. That is, there is no blood supply to the kidney, so the kidney will be slowly getting damaged. Because of the large amount of time, we knew that these kidneys are not going to work immediately. The other thing is, as you said, once we do a transplant in a live donor, once we put the kidney, immediately the urine comes from the kidney, because main function of the kidney is produce urine. So on the table the urine comes, but this patient took 2 weeks for the kidneys to recover. We also know that there is something called tubular damage, which is reversible, which takes about 2 weeks for the kidneys to come back. And when we got the kidneys, we did a biopsy on the kidney to find out, we took a small piece from the kidney to check under the microscope to find out that there is not a completely damaged kidney. There is only some amount of tubular damage, which will take 2 weeks for it to recover, and that is what we expected, and that's what happened. So both kidneys were transplanted, took 24 hours. For the next 2 weeks, this patient was managed on dialysis to take care of his kidney function. By 2 weeks, this kidney started producing urine, and his kidney function is now normal like anybody else. When we do a transplant, even in a live donor transplant, we never take the original kidneys out unless there is a specific reason to do so. Sometimes we take kidneys out because there is a source of infection, those kidneys have got stones, those kidneys have got cysts and things like that. Normally in somebody where we routinely do a live donor transplant, we don't take the kidneys out. So the patient will be left with their own kidneys, and we put an extra kidney, which is a third kidney. But in this patient has got 4 kidneys, 2 original kidneys which are not functioning and 2 transplanted kidneys which are functioning quite well. Main important message we need to convey is that when somebody dies of a head injury or a brain tumor or something, I know it's a very emotional situation for the family, for the relatives, for the next of the kin of this patient, whoever is dying, but they always need to keep one thing in mind. We know that our kith and kin are dying, but in that death you should find hope for somebody else. You should see whether this patient who is dying can live in somebody else by donating the organs, and this donation of the organs is usually voluntary. And most often as doctors, we don't go and ask the patient or relatives whether you will donate the organ. Our duty is to tell that relatives that this patient is brain dead and probably will not recover. Not probably, definitely will not recover in the future. And that's where organizations like Mohan Foundation come into play, because they are unbiased, voluntary and non-governmental organizations, and there is a lot of fairness because we need to be not only fair but also look to be fair. You also need to look to be fair, so that people don't attach motives to you for what you're doing. So in places like that, Mohan Foundation would definitely come in play. But this has to happen more often. This has to happen in a more larger scale. This has to happen in a more organized scale, so that we should have the facility in a large country like India, where there is so much population who requires organs. We should be able to fly these organs across the country. Now we have flown it from Chennai to here, but we should have the capacity to fly these organs from here to Delhi, Chandigarh, Assam, Guwahati, wherever you want. And for this, most of the Western countries have got an organized network. Every patient who requires a kidney goes on a national database, and the moment an organ is available, this organ is matched to the database, and to find out who is the best possible candidate to receive this organ, and immediately that organ is flown to that area. So we should have a more organized network, and in a country like India, where everything is progressing so fast, this is one area which we have not progressed. We have progressed medically. We have progressed by way of surgical techniques. We can do surgery as well as anybody in US or anybody in the UK. We have all the medicines like anybody else in UK or anybody, and our results are definitely as good or even better than some of the places in the West. But we don't have the infrastructure to do a better job, to prevent these kidneys organs from getting wasted. We have capacity now in Apollo Jubilee Hills to transplant kidneys, to transplant liver, to transplant heart, a lot of things which we can do in Apollo hospitals. But this requires a more organized system, so that these organs do not go waste.